Welcome to Healthcare Algorhythm. I'm Dr. Will Strimel. If you want the real story behind today's healthcare challenges and the strategies and technologies people are actually using to solve them, you're in the right place. Short conversations, clear insights, practical takeaways. Let's get into it. Hello again, and welcome back, everybody. Dr. Will Strimel here with you today on the Healthcare Algorhythm, and I'm pleased to be joined by Christine Oriol Mahoney. She is the Chief Clinical Officer of Oriol Health Care, which is a multi-generation Central Massachusetts-based senior care organization that operates 2 skilled nursing facilities, a home health agency, and outpatient rehab services. And senior care is one of the fastest growing areas and verticals within the healthcare industry in the United States. And as it grows, the care delivery model itself is changing. And that's really what we're going to dig into today. So thanks very much, Christine, for joining me.
Thank you for inviting me here.
Absolutely. And I want to say I love your company's messaging, and that is your family taking care of other families. And so, like, you've kind of made senior care the family business, right? So just maybe give me a sense of how that all got started.
Way back, I guess in the early 1960s, my father was a real estate agent and he was showing some land to, I guess, a customer who wanted to build a nursing home. And my father thought that sounded like a good idea. So he decided to build a nursing home, to do it from the ground up. He got into it. And even back in there, he looked forward to the future and put in things maybe that weren't required, but suggested, like nursing call bells. Those weren't necessarily a thing back in the early 1960s, the fire sprinklers, and trying to envision it for the long term.
Okay.
And
And
now we've
so then
grown to buying that.
no, please go ahead.
Um, And after a while, my father did purchase another nursing home for somebody who was retiring, and it kind of grew from there. Expanded one facility, and actually, the state asked them to take in ventilator patients from a state hospital that was closing at the time. I don't remember back exactly when it was, but the state hospitals were closing and they needed some place for long-term patients. So they put on a ventilator wing. They created it for long-term vent patients and to add to their services to the
Yeah.
community.
So I get the origins of what we would now know as an LTAC, right?
Yes, yes.
Long-term acute care. Yeah, for sure.
And it's nice to keep like long-term vent patients. It takes a special kind of dedication because these patients are chronic, and unfortunately, some of them came here very young. And to not just the older population, but the disabled younger population that do need chronic, long-term,
Sure.
long-term acute care.
Sure. Yeah. So you figure that was started in the 1960s, you move into the 1970s. That's when really financing for healthcare was almost at its infancy, right? And so I imagine you've probably, or
Mhm.
your family at least over time, has seen just so much in the way of evolution of how these services are paid for and how they're supported. So I would imagine it must have seemed like a daunting task at the beginning to figure out how are we going to be able to sustain and take care of especially younger patients who need all these services. So you must, from the very beginning, it must have been like, we have to really figure out how to manage things efficiently and effectively.
It is because they're always going to make sure healthcare, we're given a limited amount of resources and reimbursement, how to make it so we can continue giving the care, but in a way that we need to keep our doors open or do so and to make it so it is financially viable.
Right. Right, right. And so, you're seeing that generally that 10% of the population that often takes up about 80 to 90% of the healthcare
Yes.
costs. You've been doing this a while, obviously. How have you seen that change, at least in the last, say, 5, 10 years, or even if we go back to the Affordable Care Act, right? Because right now, of course, although healthcare costs are always on people's mind, I think we're seeing we're seeing increasing concern even publicly about how are we going to pay for healthcare. Sure that folks like you really feel that pressure too, because you're operating in an environment that requires a lot of costs and expenses. What do you see right now, and like how has it changed? What's your perspective on the way reimbursement is keeping up, not keeping up, or changing?
Let's change in the idea of value-based care and the push to financially incentivize to decrease rehospitalizations, which can be a win-win for patients, whether they're at SNFs or at home. The SNFs do have like a agency of well, group of nurse practitioner group that comes in if the nurses wonder what to keep this patient in the
And for
nursing
those
home
not familiar,
or to send them out to the
SNF is a
hospital.
skilled nursing facility, just for those who don't know that term.
Yes, skilled nursing facility. And they will come in, make recommendations, where they're all, nurse practitioners, they're providers, so they can order the test and they can assess the patient and whether the patient can be treated in-house, and if so, what the course is, or if it
Mhm.
does need to be a skilled nursing facility. I mean, a hospital.
Hospital stay.
And the same is true for home health patients. Are some insurances or and just also some standalone nurse practitioner groups or that are led by, I guess, physicians also that will come to a patient's home. And it can even be 11 o'clock at night and they will go to a patient's home and to accept, assess the patient, whether
Yeah.
they can stay, basically be treated, remaining at home or go to a hospital. And one other thing that's relatively new is the hospital at home model,
Right. Right, right. And I've heard a
which is
little
a
bit about it.
patient
I don't have any
maybe
practical
present
experience
at
with
the
it.
hospital. Well, we've had patients that have been home health patients and they go to the hospital, they're admitted, but then they're transferred back home with hospital at home and
Mhm.
they get services like a visit twice a day from a registered nurse. They have doctor visits, whether it's in person or virtual, and the ability for hospitals at home to do to do a lot of clinical monitoring
Sure,
and
sure.
assessments. So I think a lot of these patients that do receive hospital at home, at least from my point of view, are the people that more frequently tend to need or reach out to hospital-based care, more of your
Gotcha.
chronically long-term ill people.
So that hospital at home model is relatively new. It's not certainly not being utilized widespread, but I want if you think for a second, if you take these are like almost I can in my head view it as almost like a triangle of different things. You have skilled, which are these, people who obviously need a lot of services. You have home health, which in some respects is trying to support people aging in place, right? And then in the middle, you have this home health. But when you think about all three of those, what is your sense of just the overall acuity, complexity in the last 5 years? Is it as a are they all rising?
They're rising. People are living longer with multiple chronic diseases, and the likelihood of exacerbations. You get some people with CHF and just a heart failure, and they
Right.
may have a chronic respiratory disease such as emphysema. And a lot of these chronic long-term diseases, they cause exacerbations and comorbidities at the same time. So
Right.
you're treating more complex patients at in the hospital as well as the nursing facility and likewise at home.
Right, and therefore, I think it's obvious then it's more of a challenge to keep them in place, right? To keep them out of the hospital. So I think that kinda leads me into the next thing about how are you in your world, how are you thinking about that? I think if we say that's a pain point, let's say that we have, we're trying to take care of people who are increasingly sick. I've heard that, for instance, even if you look at independent living, skilled living, at home health, like these are the skilled people of, 10 years ago are now like in assisted living. So I can only imagine that the skilled side is even sicker. Folks in general are more complex. What are the most recent tools or how are you thinking about in 2026? How do you manage that? How do you what are you putting to address that?
Right now, I'm putting together a We've had a lot of things start with the new year, but one of our planned things is to start I'm gonna pioneer or lead a follow-up, a phone call, follow-up
Mhm.
communication with SNF and home health patients. It's not the kind of thing that is question driven by the government because they have different agencies, whether it's Pinnacle or whether it's, strategic health partners that send out, government kind of like mandated or, questionnaires for the patients to sign to fill out and come back. This is more of a facility based
Okay.
and to catch the patients when the first few days of being back home, like, did your home health home health agency, contact you? Do you have all the medications you need? Do you have any questions about your medications? Did you make appointments to follow up with your doctor or your provider? And try to catch those problems before any issues before they actually, snowball.
Sure, sure.
Now
Well,
that,
here's a
some of the
question
skills
for
there.
you,
Yeah.
like along those lines that, maybe you've thought of, maybe you haven't, but that's a work but you need people to do that, right? And I think that the other side of that is that
Yes.
we're all in healthcare faced with workforce challenges. Are you exploring or are you familiar with, for instance, agentic AI? Because guess what? There's platforms that can probably do that for you, that an agent can actually contact the patient and have those conversations about. I mean, is that something you're thinking about it for, or, kind of why not? And I guess the question would be cost or reimbursement. But yeah, maybe just give me an idea. Are you thinking about that? Or is that something you would think about if you had the right tool in front of you?
I think it's something we would think about and the right tool in front of us. And as you mentioned, it's all a question about reimbursement,
Right.
how to show the value of something like that. And what I'm thinking about with the value-based purchasing, it is better that we keep our patients it's better for the patients as well as for, our financial reimbursement to
Right.
avoid a patient being rehospitalized in the first 30 days,
Okay.
that they
That's
have
so
all their
that's
medications.
so that's a great point. So you would say, and I think this is especially great coming from a clinical person, because there's certain things you're going to champion. And if you're introduced to, say, a technology or a resource or something that says, hey, the real lever we can pull here in the skilled environment is this, we feel this is going to help us reduce hospitalization. That to you is a revenue driver, or a cost saver that would say leadership would rally around, hey, this is something that we want to invest in. Is that a fair statement?
I would say yes, especially that from a clinical as well as financial point of view, it's a win-win.
Okay. And so to that end, are there things out there that are coming across your desk that you're seeing in the marketplace? You go to a conference. Even if it's just buckets, like, what are the buckets of things that you think could do it? Is it care coordination? Is it, something like we just talked about, better patient engagement? What are the things that you think going in the next couple of years that have some opportunity to do that?
Well, the coordination and transitions of care is a much talked about issue because we need it smoother for the patient as well as for the healthcare entities that are transitioning, doing the transitions.
Okay.
The communication is only as good as the materials being communicated.
Right.
And I think we're looking
Garbage in,
for
garbage out.
tools.
Right.
Exactly, exactly. You gotta have the right questions, this and that. And when I was looking at different kind of questionnaires to use for, like, for the home health patients, as well as skilled nursing facility patients on our health care company following up on, I actually reached out to the accountable care organization in our area, and I
Okay.
said, "Hey, do you have anything that you're using that you can recommend?" So that way, they know that, we're looking at it, and I get a tool that's already being in use by
Mhm.
them, and then they've done the tweaking. So it's,
Okay.
I take and look at it and do further adjustments that fit our needs. But to get a tool that is more universe, that is more generally known, that's acceptable, and it's got this evidence of it working.
Yeah. Do you find that having the direct channel to is the direct channel that we're talking about, the home health patients, the communication to the patient more important, as important, or less so than the care providers, right? So I imagine even that you do have some nurse practitioners or some folks I think you mentioned who come into the facility, but these are also a lot. I imagine a lot of different
Yes.
doctors, a lot of different specialists are involved. How do you manage that?
Well, the communication always is, it's good that we've moved away from the paper
Hmm.
charting and that kind of thing. And anything when a patient does or resident does go out from the SNF to a specialist, it is, albeit a paper, copy, that it's uploaded to the electronic medical record so everyone can see it. It's some kind of information disbursement of information to the people that are able to use it for the patient's medical benefit. It needs to be there. We can't have everything cannot live in a silo. Even though
Right.
a patient may have many specialists, it gets tricky when they're especially have different healthcare organizations and
Right.
one use an Epic system, another Epic system. These even good for hospitals with CHF in the same month, and their cardiac medications are all over the place.
Do you see, that even though we have everything as electronic health records, and then do you feel that that is an effective system or an efficient system? Because sometimes they can become burdensome too. And do you feel like you have the information when you need it all the time, or is that can be a gap in care, and then that can even lead to a transition to the hospital because you didn't have that information?
That exactly what you mean. It is more of a risk to the patient
Huh?
when they do have the different providers from different entities. We have 2 major health systems here in Central Mass, my
Right.
area, and neither one of them, they both have an Epic system, but they don't talk. So I have talked to patients and told them that it's good if you can go with one system, not to have one, your general practitioner with hospital A and
Sure.
have your specialist from hospital B because they don't talk, especially where the long-term multiple chronic illnesses are impacted. We need to have the primary able to communicate and see the visits with the other healthcare providers.
Okay. Well, we've talked
And
quite a
that
bit about the
I
challenges. I was gonna say we've talked quite a bit about the challenges you're facing, but let's talk about some good stuff. I mean, what are you proud of at Oriole Health? What do you guys do really well, and what it seems like looking at your communications, you're very involved in the community. You've obviously been there for several generations, right? So I imagine you have a very strong bond with the people and the families that you serve. So what is
yes.
what tell us some good news stories here.
The good news, actually, my nephew, Nathan Oriol,
Okay.
is taking kind of over the helm now.
Okay.
And he went to school for, I guess, healthcare administration. He directly out of high school, and he got his nursing home administrator license shortly after graduating an internship. And he's been kind of immersed in this culture basically since birth. And so it's nice to see another generation
Hmm.
that's going to be managing the company. My daughter is also a registered nurse. She's doing something else at this time. She's still into the glitz of the hospital excitement.
It wears
And
off.
it's
Trust
nice
me.
to see that, well, it is, like, exciting, doing code, going, the excitement of codes is still there.
Sure.
Uh, and it's nice to see it being carried on. It's pleasant. My brothers, now that we're all 65 plus now, are more involved in not just, senior communities or senior events for the sake of the company. We're there for ourselves.
Right.
But to do those kind of connections, my brothers and I all live in the town that we went to high school in.
Wow,
And
that's
that's where
great.
Oriole Health Care is. So it's a nice thing to be involved with people, see people as patients that we went to school with, and to be able to help the community and help the families. And actually, our desire is not to grow, to get bigger. It's to go up more,
Right.
basically to offer more services and more benefits to the people in the community. We don't want to be huge. We want to be good in our specialized area.
I was just
Yeah,
gonna
it's
say
good to
that's a
be
nice
here.
little bit of a lead into, you're the changing of the guard, right? So it sounds like there's a nice little generational transfer even within the family now. And there's you're going to be some probably new, fresh perspectives that are coming in, but you've seen it all, right? And I would say if you could sit like with Nathan, your new leader, and maybe a developer or someone who can say, hey, the next 3 to 5 years, this is the big thing that we want to really attack in terms of it really improving the care that you deliver. What would you design? What would you
Yes.
suggest? What can really be different in the next couple of years that's going to really not so much revolutionize, right, but really advance that goal of not of just being even better than you've been for the last 50 years.
Well, one thing that we're looking at is a shortage of housing. And as the baby boomers, myself included, as
Hmm.
we are looking to downsize from our large homes, there's not enough of, at least we feel, of senior friendly living in the area.
Interesting.
And some people, people that live in our town want to stay in the town. And one thing is there's not enough to go up. And we are looking at the future. My brother's my nephew, and I've been looking at doing we have some property here that we
Right.
own, our company owns, and looking into doing maybe assisted living, maybe independent, living or 55 plus. That way we can stay in our community that we've been in basically our whole lives. And we can do it for the rest of our neighbors and our friends and our business associates, because once are in a community for decades, more times than not, you want to stay there.
Oh, of course. Of course. I mean, that, and especially again, you've lived through this evolution of your family business. Why wouldn't you want to stay there, right? So one of the questions I like to close with, and I think you're a perfect person to have some perspective on this, is that healthcare is hard work, right? We see people
Yes.
at their toughest. They don't really necessarily want to be involved in the service that we're providing. They have to, but there's something that keeps you going, right? There's something that most days you wake up and say, yeah, this is why I want to go out and I want to do it all over again. So, what has that been for you in your career?
It's generally a good feeling. I like seeing and enjoy seeing the people improve, people get better, people learn more, take care of themselves. And from what I've seen, helping people to help themselves. A lot of times you cannot be home without support, or you basically, or maybe you just to rephrase it, you do better with the support that's available. And looking towards the future and really feel like we've accomplished a lot.
No, and I think as I can't imagine as patients and their families, because usually this is a family decision. I'm sure they increasingly, as they're looking at options, I can't think of a better message to have than having another family take care of them. I think that's you got a fantastic organization there. I certainly hope there's some people in Central Mass who will get to hear this, and if they do, how can they reach out? How can they find you? Or what's the best way to learn more about oral health?
Well, actually, we have a website, www.oriolhealthcare, all one word.com. Oriol spelled Oriol. And for questions for admissions, for a tour, the phone number is 508-829-11. So that's how it is. And you can see my face, my nephew's face, and my brother's, and all the other people that helped to make this go on. It's a labor of love and dedication.
And it sure seems like it. And Christine, thank you so much for joining me today. Pleasure hearing about what you're doing. As I go through this, I may even have some more follow-up questions for you. So hopefully we'll reach out, we'll stay connected, and we'll learn more about what you and Nathan and the changing of the guard looks like. Okay.
That sounds good. Thank you so much for having me.
It's been a pleasure. And thank you all for listening in on the Healthcare Algorithm today. It's a pleasure having you with us, and we hope to see you on the next episode. And until then, be well.